Hypertension, the silent killer, is the level of blood pressure at which the benefits of action. Hypertension is the level of blood pressure at which the benefits of action, i.e. therapeutic intervention, exceed those of inaction. Hypertension is a medical term for elevated blood pressure. Definition: SBP or equals 140 mm Hg, DBP greater than or equals 90 mm Hg. Can also occur in children and adults but more common among people greater than 50 years old. Prevalence: 20% to 30%. In 1995%, the cause is unknown. Most of the time patient is asymptomatic. Remains the significant cause of morbidity and mortality in the world. Heart attacks, myocardial infarction -3.4%. Stroke -11.5%. Kidney damage -53%. Epidemiology: who over 972 million adults, 1 in 3 adults. What high blood pressure? We're all over the world. When typically over the age of 50. Why? Family history: being overweight, having high sodium intake. Hypertension, types: primary, essential, no pre-existing cause. Most common cardiovascular disease in the world: primary, essential, no pre-existing cause, unknown etiology. 80 to 90% of all cases. Treatment mainly symptomatic. Secondary known etiology: A. Kidney disease, B. Thyroid disease, C. Adrenal disease. Treat to eliminate cause of the disease. Office or white coat hypertension, increased in BP associated with the stress of physician office visits. May affect as 50% of hypertensive patients. Why? Causes, effects, genetics, family history, weight, obesity. Diet: too much sodium intake, diabetes, stress, smoke/alcohol. Effects: factors contributing to high blood pressure. Controllable: obesity, eating too much salt, alcohol, lack of exercise, stress, uncontrollable, race, heredity, age. Resistant hypertension: blood pressure that cannot be reduced below 140/90 of a millimeter of mercury, below 160 millimeters of mercury for ISH, in patients who are complying with adequate triple drug regimens in appropriate dosage. 50% to 75% of people being treated for hypertension, target BP is not achieved. Causes of resistant hypertension: improper blood pressure measurement, volume overload and pseudo-tolerance, excessive sodium intake, volume retention secondary to kidney disease, inadequate diuretic therapy, drug-induced, non-compliance, inadequate doses, inappropriate drug combinations, obesity, ethanol, tobacco. Assessing cause and incidence of resistant blood pressure. Inaccurate BP measurement, white coat hypertension, disease progression, suboptimal treatment, non-compliance with prescribed therapy, antagonizing substances, coexisting conditions. Secondary hypertension, causes of isolated systolic hypertension. Aging, increased aortic rigidity, increased cardiac output, thyrotoxicosis, anemia, aortic insufficiency. Patient evaluation: medical history, physical examination, routine laboratory tests, other diagnostic procedures. Assess presence of acute or rapidly progressive target organ damage. Reveal identifiable causes of hypertension. Assess the patient's lifestyle and identify other cardiovascular risk factors. Hypertension presentation. Usually asymptomatic. It doesn't refer to being tense, nervous or hyperactive. The only way to find out is to have it checked. A single reading showing high BP doesn't mean you're hypertensive, but it is a sign that you need to watch carefully. Symptoms and signs: often people are unaware: mild headache, blurring of vision, dizziness/sweating, palpitation, chest pain, difficulty of breathing, measurement of blood pressure. Physical examination: mercury sphygmomanometer, gold standard device. Brachial artery. Kirotkoff technique. Kirotkoff phase L, clear sounds, records systolic blood pressure. Kirotkoff phase V, sound disappear, record diastolic pressure. Kirotkoff phase 4, muffling, record diastolic pressure, children. Cuff size, small, overestimate BP. Bladder approximately 80% of the circumference of the arm. Seated BP reading after 5 minutes of rest. Caffeine, 30 to 60 minutes. Smoking, 15 to 30 minutes. Exogenous stimulants, phenylephrine, nasal decongestants, eye drops, secondary hypertension. What does high BP does to your body? It increases the heart's workload, causing it to enlarge and weaken over time. It must pump harder and the arteries carry blood moving under greater pressure. The elasticity or stretchiness in the arteries decreases. As the heart struggles to pump harder, the muscle wall can grow larger. A constantly elevated BP hastens the formation of plaque or fatty deposits within the blood vessel, which causes atherosclerosis, hypertension. Therefore, there is risk of stroke, congestive heart failure, kidney failure and heart attack. Those with uncontrolled BP are 1. 3x more likely to develop coronary artery disease. 2. 6x more likely to develop CHF. 3. 7x more likely to develop stroke. Hypertension affects target organs. Angina pectoris. Unstable angina. Myocardial infarction. Sudden death. Heart failure. TIA. Ischemic stroke. Hemorrhagic stroke. Renovascular disease. Renal failure. Claudication. Aneurysm. Critical limb ischemia. Clinical impact of hypertension. Increased death from ME and CHF. The second leading cause of new cases of end-stage renal disease. 2 to 4-fold increase in strokes. Clinical impact of diabetes mellitus. Contributes to visual loss in people with diabetes. Clinical disorders resulting from hypertension and atherosclerosis. Congestive heart failure. Cerebral hemorrhage. Renal failure. Retinopathy. Dissecting aneurysm. Hypertensive crisis. Coronary artery disease. Angina pectoris. Myocardial infarction. 2 degrees renovascular hypertension. Peripheral vascular insufficiency. Cerebral thrombosis, stroke. Risk factors for cardiovascular complications in hypertensive subjects. Age. Sex. Race. Hyperlipoproteinemia. Diabetes mellitus. Cigarette smoking. Obesity. Salt intake. Previous cardiovascular disease. Family history of cardiovascular disease. Diagnostic workup of hypertension. Assess risk factors and comorbidities. Reveal identifiable causes of hypertension: sleep apnea, drug-induced related, chronic kidney disease, primordialdosteronism, thyroid diseases, Cushing.S syndrome. Assess presence of target organ damage. Conduct history and physical examination. Obtain lab test. Complete blood count, CBC. Urinalysis. Chest X-ray. Lipid profile, total cholesterol/triglycerides/LDL/HDL. Other blood chemistry, ALT/AST/bun/creatinine/uric acid. Obtain ECG and other workups. Treatment of hypertension. Goals of therapy: reduction of cardiovascular and renal morbidity and mortality. Treating SBP and DBP to targets that are less than 140/90ths of a millimeter of mercury is associated with a decrease in CVD complications. Hypertension and diabetes or renal disease, the BP goal is less than 130/80. To decrease cerebrovascular accidents 35 to 40%. Coronary events 20 to 25%. Heart failure 50%. Progression of renal disease. Progression to severe hypertension. All-cause mortality, factors to consider in treating hypertension. Repeat readings. RO, secondary causes. Estimate CV risk status. Comorbid conditions. Lifestyle changes. Drugs, treatment of hypertension. Non-pharmacological. Pharmacotherapy. Restriction of salt intake. Reduction of body weight. Cardiac output, SHARP-S blockers, CAR2+ channel blockers. Plasma volume, diuretics. Peripheral vascular resistance, vasodilators. MAP equals COXT. Treatment, non-pharmacological. Maintain a healthy body weight. Lose weight if needed. Obesity causes the heart to work harder. Eat a well-balanced diet including fresh fruits and vegetables and low-fat dairy product. Avoid eating high-fat, high-cholesterol foods which promote atherosclerosis. Reduce sodium in your diet because it leads to water retention and increase heart workload. Exercise regularly. Stop smoking. Lifestyle modification recommendations. RV-SBP reduction range. Weight reduction. Maintain normal body weight, BMI equals 18.5 to 24.9 kilograms per square meter. 5 to 20 millimeters of mercury/10 kilograms. Eating plan. Adopted diet rich in fruits, vegetables, and low-fat dairy products with reduced content of saturated and total fat. 8 to 14 millimeters Hg. Dietary sodium reduction. Reduce dietary sodium intake to less than or equal to 100 ml/day, 2.4 grams Na or 6 grams NaCl. 2 to 8 millimeters Hg. Aerobic physical activity. Regular aerobic physical activity, e.g., brisk walking, at least 30 minutes/day, most days of the week. 4 to 9 millimeters Hg. Pharmacologic therapy. Consider severity of BP. End organ damage, including LVH. Presence of other conditions or risk factors, DM, CHD, smoking, LDL. 50% of patients controlled with one drug, another 30% with two. The vast majority of patients with diabetes require 2 or more drugs. Hopefully you have a sense by now that consideration of when to begin pharmacologic therapy should take into account, as well as your clinical sense of patients' functional abilities and potential for adherence to treatment plans. I will now do a lightning review of various pharmacologic therapies with special emphasis on mode of action, adverse effects, and usefulness of each agent class on various comorbidities. You can follow along with your syllabus by using the table at the end of the syllabus for annotations. Adverse effects for each class of agents is included on pages 2. Individualized care renin status risk factors considered. Non-pharmacological therapy tried first. Monotherapy is instituted. Considerations for choice of initial monotherapy. Renin status. Coexisting cardiovascular conditions. Other conditions. Treatment, pharmacological. Medication is often necessary to control BP. It is imperative to follow your physician's instruction in taking your medications. Take your medicine daily as prescribed and never stop it unless instructed. Threshold for initiation of treatment and target values. Condition. Initiation. SBP/DBP-Hg. Diastolic plus minus systolic hypertension. 140/90. Isolated systolic hypertension. SBP equals or greater than 160. Diabetes. 130/80. Renal disease. 130/80. Proteinuria greater than 1 gram/day. 125/75. Target. SBP/DBP-Hg. Less than 140/90. Less than 140. Less than 130/80. Less than 125/75. Drugs for hypertension. Direct vasodilators. Calcium channel blockers. Dihydropyridine. Non-dihydropyridine. ACE inhibitors. Angiotensin II blockers. Diuretics. Thiazide. Loop diuretics. Aldosterone antagonists. K-sparing. Adrenergic inhibitors. Peripheral agents. Central alpha agonists. Alpha blockers. Beta blockers. Alpha plus beta blockers. Usually not monotherapy. JNC7, Management of Hypertension by Blood Pressure Classification. Initial drug therapy. BP classification. Lifestyle modification. Without compelling indication. With compelling indication. Normal. Less than 1/128th of a millimeter of mercury. Encouraged. Pre-hypertension. 120 to 139, 80 to 89 millimeters of mercury. Yes. No drug indicated. Drugs for the compelling indications. Stage I hypertension. 140 to 159, 90 to 99 millimeters of mercury. Thiazide type diuretics for most, may consider ACE-I, ARB, BB, CCB, or combination. Drugs for the compelling indications, other antihypertensive drugs, diuretics, ACE-I, ARB, BB, CCB, as needed. Stage 2 hypertension. Greater than 160/100ths of a millimeter of mercury. 2-drug combination for most, usually thiazide type diuretic and ACE-I, ARB, BB, or CCB. ACE-I equals angiotensin converting enzyme inhibitor, ARB equals angiotensin receptor blocker, BB equals beta blocker, CCB equals calcium channel blocker. Kabanian Avenue et al. JAMA. 2003, 289, 2560-2572. Compelling indications for individual drug classes. Initial therapy options. Heart failure. Thiaz, BB.ACE1, ARB, aldo-ANT. Post-ME. BB, ACE-I, aldo-ANT. High CVD risk. Thiaz, BB, ACE-I, CCB. DM. Thiaz, BB, ACE-I, ARB, CCB. Chronic kidney disease. ACE-I, ARB. Recurrent stroke prevention. Thiaz, ACE-I. Key, Thiaz equals thiazide diuretic, OK equals angiotensin converting enzyme inhibitor, ARB equals angiotensin receptor blocker, BB equals beta blocker, CCB equals calcium channel blocker, aldo-ANT equals aldosterone antagonist. Dental treatment and hypertension. Hypertension in dentistry. Patients have to be treated with care. Risks of heart failure/heart attack. Patients must be monitored continuously. Many patients with hypertension also have metabolic syndrome, which is likely to develop periodontal disease due to an increase in buildup of calculus around the gums. Common health issues can disrupt not only overall dietary health, but also dental health. Hypertension in dentistry. The risk of providing dental treatment to patients with hypertension is low. LA-containing epinephrine can be used with little risk in dental patients with hypertension. For patients taking a non-selective beta blocker, use epinephrine cautiously, max of 2 carpules of 1 to 100,000 epi. Gingival hyperplasia is common in patients taking a calcium channel blocker. Elective dental treatment should be deferred in patients with a blood pressure greater than or equal to 180/110, uncontrolled blood pressure. Implications for dentistry. Care in use of vasoconstrictors, for example supersensitivity to catecholamines with guanethidine. Orthostatic hypertension, common to all antihypertensive drugs. Judicious use of SNES depressants, especially with centrally acting antihypertensive drugs. Salivary inhibition, xerostomia common with centrally acting antihypertensive drugs. NSAIDs, decrease action of captopril, spironolactone, furosemide. Gingival hyperplasia, with long-term use of CAR2+ channel blockers. Summary points. Hypertension is defined as a sustained blood pressure greater than or equal to 140/90. Any level of hypertension is associated with an increased risk of cardiovascular disease. Hypertension remains an asymptomatic disease for long periods of time. Many patients with hypertension are unaware of their disease. Many patients with hypertension are non-compliant with medication and thus are not well controlled. Elevated blood pressure cannot be cured, it can only be controlled. And its effects can be prevented or reduced if it is treated and controlled early. Hypertensive crisis, hypertensive urgency, hypertensive emergency. Increased in diastolic blood pressure. Greater than 120 to 130 mm of mercury. No end organ damage. Lowers down BP within 24 hours. Hypertensive emergency. Systolic BP exceeding 210 mm of mercury and diastolic BP greater than 130 mm of mercury. With end organ damage, for example, acute MI, ICH, unstable angina and hypertensive encephalopathy. Requires immediate BP reduction within an hour, 4 medications. What is the primary reason for hypertensive emergencies? Renovascular disease. Pheochromocytoma. Non-adherence to antihypertensive medication. Hyperaldosteronism. Erythropoietin. Clinical presentation. Variable. Mean systolic BP 210 plus 32. Mean diastolic BP 130 plus 15. Frequency of signs and symptoms. Chest pain 27%. Dyspnea 22%. Neuro defect 21%. Interestingly, headache was only 3% and epistaxis was 0%. Threshold BP. There is no specific BP where hypertensive emergencies occur. But, organ dysfunction is rare with diastolic BPs less than 130 mm Hg. Rate of increase may be more important. Hence, encephalopathy will occur at lower BPs in pregnancy and in children. 46. Hypertensive emergency. SNES, encephalopathy, intracranial hemorrhage, grade 3 to 4 retinopathy. Heart, CHF, ME, angina. Kidneys, acute kidney injury, microscopic hematuria. Vasculature, aortic dissection, eclampsia. 47. Initial evaluation, social history, focused history, recreational drugs. History of hypertension. How well is hypertension controlled? What antihypertensives? Adherence to antihypertensive regimen? Last dose of antihypertensive? Social history. Recreational drugs. Amphetamines. Cocaine. Phencyclidine. Initial evaluation confirm BP in both arms. Use appropriate sized BP cuff. Cuff that is too small. BP cuffs that are too small falsely elevate BP measurements in obese patients. Assess for end organ damage. Vascular disease. Assess pulses in all extremities. Auscultate over renal arteries for brutes. Cardiopulmonary. Listen for rales, CHF. Murmurs or gallops. Initial evaluation neurologic exam retinal exam ECG. Hypertensive encephalopathy, mental status changes, nausea, vomiting, seizures. Lateralizing signs uncommon and suggest cerebrovascular accident. Retinal exam. Lost heart. Keith-Wagner-Barker classification. ECG. LVH, look for signs of ischemia, injury, infarct. Renal function tests, urine included. Elevated BUN, creatinine, proteinuria, hematuria. CBC. CXR, pulmonary edema, aortic arch, cardiac enlargement. Lab testing aortic dissection, pulmonary edema/CHF. Suspect with severe tearing chest pain, unequal pulses, widened mediastinum. Contrast chest CT scan or MRI. Pulmonary edema/CHF. Transthoracic echocardiogram. Differentiate between systolic dysfunction, diastolic dysfunction, mitral regurgitation. 51. Management elevated BP without target organ damage. Hypertensive urgency. Oral meds. Goal, gradual reduction of BP over 24 to 48 hours. Elevated BP with target organ damage. Hypertensive emergency. Parenteral meds. Goal, reduce diastolic BP by 10 to 15% or to 110 mm Hg over a period of 30 to 60 minutes. 52. Management where? Which parenteral meds? Depends on the situation. ICU with close monitoring. Severe requires intraarterial BP monitoring. Which parenteral meds? Depends on the situation. 53.